Thank you very much, Sylvia. Good morning, everybody. As Sylvia said, I'm going to give you an overview of what we've actually been doing with our CEDA ICCM program that's been funded by Canadian International Development Agency. So looking at how we've been working to improve access to quality of and demand for ICCM services. So the first thing I wanted to do in this presentation was just look at how do we define ICCM? So I took this definition, which comes from the core group on community case management, because I think it's a very comprehensive definition. And you can see it's clearly talking about treatment for childhood illnesses in areas where there's limited or little access to health facility services. And that if you have an effective strategy, it will increase, as we said, access, quality of and demand for the services. But ensure also that CCM has the support of the decision makers, the healthcare providers and community members, so all aspects, and is put into action in tandem with improvements in the health service. And I think that last point is very important. ICCM does not stand alone. It's very important. It is linked quite strongly to the health service. And if it's done effectively, it should upgrade the skills of the existing community health workers in the system so that they can deliver these services and ensure strong links to existing health facilities. Okay, so that's the definition for community case management. Integrated community case management specifically is defined by that it tackles major childhood illnesses. So it's not just one illness. We're looking at particularly malaria, pneumonia and diarrhea in children under 5 years. And that being integrated, it emphasizes a holistic approach. So you're also looking at things like behavior change communications to get good use of the service and understanding of it, and integrated, as I said, with the health system and strengthening the health system. And it needs to work with a variety of different stakeholders in health. This slide really is just to summarize how the situation was 4 or 5 years ago, around the time where we started working in ICCM, looking at some of our focal countries. So, for example, in Mozambique, you had APEs, who were community agents that had been working for a very long time. It's a long history there, since the 1970s. But over time, the services had become very fragmented and not very harmonized. So, and it was mainly around health promotion and very simple first aid and some treatment of malaria, primarily. And the decision was made by the government to revitalize this whole strategy in 2010. In South Sudan, there's no official policy as such, and there wasn't then either. But because of the very poor and limited health infrastructure, there has been a long history of community-level care, mainly implemented by NGO health partners. In Uganda, there is the strategy of the village health teams for health promotion has existed for a number of years. You have 4 or 5 per village, and they receive 6 days training on health promotion. So they were already in the system, as I said, 4 or 5 years ago. And then in Zambia, you had a program where community health workers had received 6 weeks training, again, mainly on health promotion activities. And although they were meant to do some treatments, including, again, of malaria, the support of the supplies and the drugs never really followed them, so they really didn't do much treatment there at that time. So in terms of, again, 4 or 5 years ago, when we look at the common gaps that were there was a lack of a strong ICCM policy in most countries. Our existing one needed to be revised to really become updated. There are more effective tools for diagnosis and treatment that are really suitable for use at community level, and also the need to update the related training curriculum and materials. Then, as I said, there was a need really in many countries to have much stronger harmonization of different programs that were already existing and functioning at community level across different parts of the Ministry of Health, so that bring them together under an ICCM strategy. And another thing which I think is still coming online in most countries is the need to have a health management information system that will also include data from community level. In most countries this doesn't really exist or is at a very early stage of development. So that was, as I said, the landscape. So at the time, I'm talking about 2008, 2009. In 2009, Malaria Consortium received a grant from Canadian International Development Agency, CEDA, to implement ICCM in large scale in a number of different settings, really to respond to these, really to move forward knowing that we had new tools and could do a more effective approach. In this grant, the objectives, the goal was to reduce child mortality, specifically under 5 mortality, and morbidity and mortality by up to 35% was our target. We started in April 2009 and completed in March of this year. Within our grant, we had criteria, as you see here, listed on where we could actually implement it. It was clear that it was important to reach areas where under 5 mortality was really quite an issue, as you see above 120 per 1,000 live births, and with a high proportion attributable to pneumonia and malaria. And because it was quite an ambitious project, it was very important to implement in places where Malaria Consortium already had a presence and a strong relationship with the Ministry, and the Ministry was already ready to move forward with this strategy. So you can see here where exactly we implemented the same countries: Midwestern Uganda, Inhambane province, Mozambique, Luapula province in Zambia, and then most of Unity State, except for one county in South Sudan, reaching a total target population of around 5 million. From the very beginning, Malaria Consortium felt it was very important to have very much an embedded project within the Ministry of Health structures and systems, and to really get their engagement, and for the project to be right within the existing processes, and to, through the project, be able to get strong ministry involvement and ownership, and using our technical capacity working with the ministry to strengthen national policies, guidelines and implementation strategies. And mostly we did this, especially in the early days, through participation in relevant national technical working groups, but it carried on at all levels, at the level of provincial and district and community level, just working very much in partnership to strengthen. And this is just a summary slide of the different aspects of how we did implement. So you see clearly it was a treatment of these illnesses, as I mentioned, in under 5s, introducing diagnostics and drug formulations that were particularly suited for use at community level. We had a unit dose and pre-packaged, so we had very clear packaging in terms of when you would give the dose and how much, and this was for the caregiver. Very important that one of the first activities we did in terms of rolling it out was refresher training of the health facility staff, so that they had an understanding of the components of ICCM and were enabled to act as supervisors of the people implementing it. And we gave a lot of inputs into the training materials and curricula, including developing job aids specifically suitable, again, for people working at community level. Continued after the training, giving supported supervision, but this was not Malaria Consortium. This was working with the Ministry of Health to do the supervision, working again to collect data from the implementers. And as I mentioned earlier, the behaviour change communication aspect, so working with the communities to increase understanding of what ICCM is, in fact, what good health-seeking behaviour is, and increasing usage. And very importantly, which will come up later in the day even more, is a comprehensive evaluation of the programme. A little bit, this slide is giving you just a bit more detail in terms of what we did in terms of treatment. So we had rapid diagnostic tests for malaria in all of the countries except South Sudan. And the treatment was an ACT, artemether lumefantrine, again with the exception of South Sudan, and where it was a co-formulated artesunate and amidiaquine. The reason we have these changes, just to say again, is that we're working very much within national policies. So, for example, with malaria, the core, our essential element was to make sure that ACT was the drug, but we followed the national strategy in terms of which drug that would be. Again, for pneumonia, we had in all of the countries the respiratory timer and dispersible amoxicillin tablets, which are more stable and easier to give to young children. And for diarrhea, we had low osmolarity, the oral rehydration solution, and zinc supplement. This was across all of the countries, but we had a phased approach in Zambia and South Sudan, where it was introduced, scheduled to be introduced in the second year. Some of the countries we had paracetamol in Zambia and Mozambique, but again, the other 2 countries felt that they weren't comfortable to have this drug at community level, so it was left out of the package. I think very important to clarify that all of the treatments at community level are for simple cases of illness. Any severe illness, the implementers were trained how to recognize danger signs and then refer to a health facility. The one thing that we do have in Uganda and Mozambique is a pre-referral treatment for severe pneumonia, which is rectal artesunate. Okay, so then, having worked with the Ministries of Health as the first part of our program, particularly again 2009, 2010, and defining a national strategy, this is what, in fact, we worked with the ministries to implement. So again, as I said, Mozambique has the APEs in the national policy. They should be doing 80% health promotion and just 20% treatment. So it's just one component of their training to do ICCM. They do receive a subsidy of rough equivalent of $40 per month, and the Ministry of Health, the government, is trying to roll it out in phases. So in the first phase, their scale is 25 APAGE per district, regardless of the size of the district. In South Sudan, as I said, there isn't a national policy as such, but it's recognized through many programs, partners programs, that community drug distributors are community volunteers who will do this work. And we, Malaria Consortium, trained them for 6 days in ICCM. But there is a guideline, a national guideline for the coverage, so it should be 1 CDD per 40 households. As I mentioned, you had the health promotion VHTs, the village health teams in Uganda, and who had already received the health promotion training. In the new strategy, 2 members of each team were then taken to given a further 6 days of training on ICCM. So you end up with each village having 2 trained ICCM VHTs. In Zambia, there's no model for ICCM, there's no policy as yet, but there are many guidelines and strategies already approved, for example, specifically for malaria and through the Child Health Programme. So that was a very enabling environment there. So, when did we implement and for how long? Again, just bearing in mind all the time that this is very much working with the ministries to get their strategies and policies in place and bring them to the stage of actually being able to implement it. You'll see there was quite a bit of variation between the countries. Uganda was the first to start implementing in the middle of 2010. This timeline is only to December 2012, but we continue to implement in Uganda beyond this particular program. And in Zambia, it's a similar, just slightly shorter timeline, continuing into 2013. South Sudan, we started a little bit later than both, and then unfortunately in South Sudan, because of where we were in Unity State near the border, we had a lot of security issues and had to make the difficult choice in early 2012 to actually close the program earlier than we had scheduled, so that's why that's finishing earlier. In Mozambique, as I had mentioned, they had the government, we worked with the government to develop a revitalized strategy for the APAGE program. It was quite a comprehensive process, and it took, as you can see, quite a lot of time. So we weren't, in fact, really able to train the APAGE until late 2011, and then they started their activities in roughly April 2012, and that's why we have a much shorter implementation line there. But we also do continue with that program, thankfully, in Mozambique to strengthen the implementation. Just a slide, just how important it was in our experience, and we put a lot of time and thought into how to sensitize and introduce this program into the 4 countries. Without giving this enough thought and attention, it can be very difficult to get good buy-in at different levels, right down to community levels. So we started, obviously, at national level to introduce the project and the funding at national level, particularly at the Ministry of Health, and to gain approval to implement and to go and talk to the authorities at subnational level. We carried on to that level, provincial and state level, and to introduce the project again in some of the countries we drafted memorandums of understanding to clearly define the roles and responsibility, but in all of the countries we worked with them and agreed with them how we would work together to develop common work plans, etc. Went then down to district or county level in South Sudan, and again with the health authorities, and we had the meetings with them first, and then in partnership with them went to the level of the communities using the existing normal structures for passing information to the communities with the community leaders and to introduce the program to them. So from the very, very beginning, this program the idea was never to have it seen as something separate, that we were really working in partnership with the Ministry of Health. And this is particularly important when you get to community level, because one of the components, which I haven't actually written here. When you are selecting the community health workers, this selection should be done by the communities themselves to select who they want to do this work for them. So the next few slides are really more detailed about how we implemented the different components that I showed you earlier. So the common elements, if you look across the top, if we take the training aspect, again, as I said, where they were in place, we always followed the MOH guidelines, which we had given input into already in the development of, and the tools specifically developed in the country, and job aids to strengthen the message and the training. Always, we used adult-focused participatory training methodology to strengthen how the message was being communicated and ensure that it was very clear, because most of our training durations were so short. We had to make sure it was very effective. Again, as I mentioned earlier, very important as the first step before you even get to community level that you have trained the health facility staff in ICCM, refresher training in IMCI, trained them also as trainers of the community agents, and trained them as supervisors for the ICCM practitioners. Then this table below is just to kind of highlight some of the differences that we did have depending on the country. So you see, like I said earlier, South Sudan doesn't have a strategy as yet, so we developed our own materials based on these principles, but they have been shared with the MOH and with other implementing partners through the technical working group at national level, which is hosted by the Ministry of Health. Interesting observation here, most of the countries, the gender balance for the people who are trained in ICCM is more or less even, with the exception of South Sudan, whereas by far many more women than men. Again, as I said, our training program was normally 6 days, but in Mozambique, where the full training for the APAGE, which includes all the health promotion components as well, is 4 months. There were 2 weeks of ICCM plus 2 weeks of practice in a health facility on ICCM practice. And the training, so again, most of the countries it was a cascade training where you start at a more central level, you do training of trainers, they go ahead and they train the next level as sometimes that's also training of trainers depending on the scale, and then that goes down to the training of the implementers. And that was really necessary. For example, if we take Uganda, we had a target to train over 6,700 BHTs in ICCM, so you had to have that cascade approach. But as I said, in Mozambique we had a lot less APAGE per district, so we did a training at central level of trainers, and they directly trained the APAGE in the districts. And just to make the point, when you're thinking about cost and implementation, whether a training is residential or not makes a big difference. So most of the countries it was residential, again with the exceptions of, well, half of them were residential, and South Sudan and Uganda non-residential. Behaviour change communication, which I've mentioned, is as being quite important. Just to say how we did it, we started by doing formative research in all of the countries, just to understand the context and to use that information to develop a BCC strategy that was context specific and more relevant to the communities. The main tool or approach that we used in all of the countries was community dialogue. So the strategy where you train people, community members, we used the CHWs and community leaders how to lead a dialogue, which is about, you can have a dialogue that's themed around malaria, one for example around pneumonia, relevant issues, and to get the communities to discuss what they understand when their child has malaria, for example, what they do, and to work with them to understand what's the most effective health-seeking behaviour. And then we had some other components. In Mozambique, we also developed a radio program series just on the APAGE and how they could work in their communities, some radio spots in Mozambique and Uganda. In terms of the support given by Malaria Consortium on this, as I said, we supported the training, and we supported an agency to develop the radio program, but again, everything was with the ministry, approved by the ministry, and we were lucky in Zambia that we had additional funds from DFID to have a dedicated BCC officer. We didn't have that in the other countries. And just a note to say, it's just these 3 countries, because as I said, security in South Sudan didn't allow us to implement there. Supported supervision, again, similar models across the countries. Just to make the difference, in South Sudan, we had to use also community monitors as well as health facility staff because there are very few health facilities especially where we were implementing in South Sudan. Another important difference to mention on this slide is Malaria Consortium had to, again in South Sudan, pay the supervisors per completed form submitted, so completed supervision form that was submitted back to Malaria Consortium, because there wasn't an infrastructure for the forms really to be managed by the health facilities. And the activities are mainly a mixture of home visits and quarterly group meetings. You can imagine that home visits are a little bit harder logistically to organize and more expensive, so we had to have a mix. Data collection, and yeah, I know Jeffrey will talk a little bit more about this, and just to say that it's normally through the health system again, so the APATE is sending it to the health facility, but as I said, South Sudan, it was directly to the Malaria Consortium office. It varies in frequency. Uganda and Zambia is mainly quarterly based, and in South Sudan, Uganda and Zambia, we were getting summary forms directly, but in Mozambique, we get that from the HMIS system, so it's all gathered through the MOH system, and we pick it up from the HMIS. And we facilitate a little bit for the parish coordinators, for example, in Uganda, their transport costs, and Mozambique we do not, and I already mentioned about paying in South Sudan. A quick slide then, one of the components of the project was that we were able to provide all the supplies necessary for ICCM, so just to talk about how we did it, through international procurement. I mentioned already how we use unit dose prepackaged. In some of the countries, we had to get special approval from the National Drug Authority to use some of these components at community level. For example, in Uganda, it wasn't standard practice for the rapid diagnostic tests, and also in Zambia, the use of amoxicillin at community level. Again, using the MOH systems as much as possible and working with them to develop stock management tools, and gave training for stock management to the supervisors and implementers. Another component of this, we had the opportunity to do operational research, really to answer questions that were still there. As I said, this is still a relatively new strategy, so trying to understand and answer questions, particularly around feasibility and quality of service delivered, that could inform policy development. We did a very small pilot of the use of mobile phones for reporting for the VHTs in Uganda, for example, and I think Karen will talk later about how another project has now moved forward to another level with that. We had a study which you'll hear about a little bit later this morning about the use of antibiotics in Zambia. Another study we did in Uganda about how quality of care and interpersonal skills are closely linked. And the next presentation, in fact, will be the results, preliminary results of a participatory evaluation which was funded by DFID, which was really a way of recording and documenting the experience that we've had in implementing. I wanted to mention other projects and partners that we have worked with that really made a big difference to how we've implemented this. We have a project which is funded by the Gates Foundation called InScale, which has helped particularly in the area of costing, how you cost the strategy. It has a focus on evaluating new innovations and a strong advocacy component, and we'll hear a little bit more about that later. We have a pioneer project in Midwestern Uganda in the same areas where we're implementing CEDA, which is funded by Comic Relief, Planet Wheeler funding, which we shared in Mozambique. The DFID PPA, which I mentioned, for the participatory evaluation, and also another DFID project called COMDIS HSD for the operational research, and that was the research in Zambia was co-funded there. Strong partnership with UNICEF. In Mozambique, for example, we shared the cost of the rollout of the training in Inhambane province, and UNICEF funded another ICCM project called ICCM Central in Uganda, which has very strong links and has benefited a lot from the materials developed in the CEDA project. Save the Children, in particular in Mozambique, we worked very closely with them to have a harmonized approach in giving technical support and inputs to the development of the revitalization of the policy there. And also in South Sudan, we've teamed with them and IRC to do a joint end-line survey. Just to kind of bring it all together, what I've been talking about then, this is quite a busy slide. It comes from David Marsh, the supplement in the American Journal of Tropical Medicine last year. It's also well circulated, but just showing the different aspects of how you implement an ICCM strategy. The components here you see in the yellow boxes, and addressing the different aspects, access, quality, demand, and particularly policy, how that can be moves on to the use, how you get people, how you use it and how it's implemented, the health system factors which you mentioned. You have the implementation happening, which has an impact on morbidity and mortality, particularly in under fives. But the boxes at the bottom, the more red boxes, are really just to show how important it is for the Ministry of Health, how they can really support this strategy and give the enabling environment, particularly, for example, the drug legislation regulations. That would be a good example, setting up the technical working groups and where necessary, and they have done this with our project on a number of occasions, facilitate provision of supplies, and from that to build up this strategy that can be implemented to impact on under 5 mortality and morbidity. So essentially, just to summarize our learnings, we use a model, as I showed you, that has essential elements but does need to be adapted to different contexts to make sure it actually works in reality and is feasible. ICCM is a mechanism for health system strengthening, working with the health facilities particularly, but at all levels, right up to the central level. And the fact that now ICCM can be more effective because of the presence of new tools, diagnostic and tools and treatments that are suitable for community level use. And we feel very strongly that our approach of working with the ministry from the very beginning and embedding the implementation there has really contributed to the transition of management of ICCM implementation to the Ministry of Health. So Malaria Consortium is a pioneer and innovator in building capacity and systems for increased coverage of life-saving interventions for major childhood illnesses. And that's it. Thank you.
Thank you very much, Helen. I'd now like to open for questions and some discussion. We'll just have about 5 minutes for that, and would like to start off with our friends and colleagues who are online. So maybe we could start off with the first, maybe 1 or 2 questions, if there are any. None yet. Okay, so based on this presentation, what are the sort of points for clarification or important points that you'd like to raise? I think Helen, you can. Helen, do you want to come and sit, or you want?
Okay, yeah. Very happy to do that.
Quick question, Helen. You mentioned in your presentation about training at the health facility that was implementing IMCI versus integrated community case management. Can you comment about that? How IMCI was going at the facility, and whether this intervention actually changed how they were managing patients at a facility-based way? Because we really want to look at the continuum of care. So I'm curious what's happening with IMCI, and of course there's a lot of foibles around facility-based treatment, but can you comment a little on that?
Certainly. I can't give you the one answer for all different 4 countries. I mean, obviously it did vary quite a lot. But I think it's very important to use IMCI as an entry point, particularly with health facility workers, to ICCM, because that's that's the area that, especially at that time, they were most likely to have had stronger training on. So when we did the training, we structured it in such a way that we started with a refresher of IMCI and then moved it into the ICCM approach. And it did vary quite a lot, but generally they were quite appreciative of having something at community level that certainly relieved their workload quite a lot. And I think it probably helped them to feel that they had more attention again in how they were implementing IMCI within the facility. So I always see a generally positive impact.
James, would you like to say something about that, your experience in Uganda?
Yeah, I think in Uganda it's more we had to do a bridged training for IMCI, and the core switched from more of the IMCI managing of cases to more managing severe cases that are referred from the ICCM program. And it is much, much easier to train community health workers if you already trained in IMCI. It closes the gap. So it really brings you, it becomes much easier for you to understand ICCM if you know IMCI. So we have to go there. And then also support supervision, but critically managing of severe cases, because now the number of uncomplicated cases will be managed at a community level. But those who are complicated will be referred to the LSA facility. So the LSA facility need to know what to do when you have severe cases. So this is really a core. It's just like having a community IMCI, which is ICCM.
Okay. All right, one more question. Eleni, any questions from the web? Yes? Okay. No, first.
Hi, Darryl Burnaby from GlaxoSmithKline. So again, just to reiterate, we do a lot of work with training community health workers, and one of the issues that we find through our partners that deliver it are along retention and pay for those community health workers. Have you experienced any of those issues with the health workers that you work through, and how have you addressed those?
Okay, maybe just Helen touch on it. And just say, Darren, subsequent presentations are going to look at some of those issues. Yeah, but maybe Helen.
Yeah. It's, do you mean particularly for the implementers, the community members?
Yeah, the community health workers themselves. You know, I guess some of the issues, as I say, that we experience or that we hear of are around continual professional development, salaries, a lot of the volunteers, retention. Sorry. Salary, retention, professional development, supervision, you know, to ensure that the training that is delivered for them to do the community-based interventions are sustainable, and you're not having to cycle through lots of different people regularly.
Yeah, I mean, I think it's a very topical issue, but in reality, in our project, certainly, people were highly motivated by other factors, such as status in the community, being able to help their own community, and they came across as stronger components, and it was very clear that this was not, except, as I said, with the exception with Mozambique, where they do get a subsidy, but in fact you see it's not very much. It's not the biggest driver, it's not a big issue, and you'll see later on when we talk about the findings, we have actually relatively low attrition rates in the projects. Yeah.
All right, Eleni from the web, from the chat room.
We have a couple of questions from Bunmi Ibotia from Friends Africa, asking how are the CHWs trained to identify danger signs for referral? Shall I just go through them all and then we answer them all?
Okay,
together?
maybe just ask the first three and then take notes.
Okay. Yeah. From Stefan Peterson of Karolinska Institute, saying, how do you see the potential for also integrating newborn work in ICCM? Florine from MCCCAM in Cameroon, asking, can we clarify what were the key challenges in implementing ICCM? And there's just one more. Also from Stefan Peterson, asking, ICCM is now almost exclusively targeting CHWs. During the day, can we consider the potential to implement also through private sector?
Yeah.
Okay, some comment, responses? Helen?
Okay, just very quickly, the one about how we train them to recognize danger signs. So we have job aids that have graphics showing the danger signs, and we give them quite clear guidelines exactly of how to recognize danger signs, and where possible we do also give them some opportunities to practice at a health facility to do the screening. I think the newborn, the inclusion of the newborn component is certainly a very interesting one, and I know that our colleague from the Ministry of Health in Uganda will mention this in his presentation. It's something that's part, in fact, of the strategy in Uganda, the national strategy, but we didn't include it in our program directly, a little bit. And then the private sector, another pertinent area, which is very country specific, and I think my colleagues can probably add more to that.
Okay, James, any more comments?
Yeah, in Uganda we newborn integration, yes, it is integrated in the package for ICCM in Uganda, so it is indeed integrated. Identification of danger signs, as Helen mentioned, the training is more of participatory and clinical assessment, so we have visits to the LSF facilities to see children with danger signs. So it involves the recognition of the danger signs and also the job aid tackles on that. ICCM in the private sector, right now in Malaria Consortium, we never took it up, but in Uganda, we operate in one district where there is also ICCM in the private sector, and this is done by a partner called PSI. So there is also ICCM, there is a potential of ICCM in the private sector also. At least that one has been tried out in Uganda. Challenges of implementing ICCM, I think Helen, alluded to that, and in more other presentation it will come clear as we go along.
Okay. One last question, otherwise we'll go for a break.
Maybe I did forget to respond to the challenges one, and maybe just to summarize, I think the areas that are most challenging and need most, some of the areas are really around supportive supervision and data collection. Yeah.
Okay, I think on that note, I'd like to wrap this presentation up, and then we'll have a 10-minute break, and then we'll come back and continue with the rest of the presentations. So 10 minutes, please.